They're gone.
Our friends in El Paso,
We're here at Kerrville.
we're there in Kerrville. Okay, good deal. We're ready to start on the next session. We have Dr. Toni Miles.
Okay. I need to know what kind of healthcare professional you are in Kerrville. Can you tell me what you do?
Dr. Miles, I'm Pat Renando, and I'm the associate chief nurse for extended care.
Okay.
And I'm Geri Rosa. I'm a QM clinician as well as a clinical nurse specialist in gerontological nursing. I'm Geri Blackwood. I'm the nurse manager of home-based primary care.
Okay. All right. How about our El Paso people? Have they left us? I think El Paso's gone on a siesta.
She's coming right back, the lady who's here in El Paso.
Oh, it's just one there. Okay.
Yes.
All right. Okay. Well, how about you guys in the room?
MD with the veteran administration.
Okay. Okay.
Dr. Rodriguez, we have a private practice.
Okay. We know Dr. Pollock in the back munching on chocolate cookies. How about you, sir?
Tim Mooney, internal medicine, VA assistant.
Okay. Oh, this is great. So this is like a VA colloquium. I like this. This is good. This is good. I've been wanting to talk to the VA docs anyway more about geriatrics. My name is Toni Miles, and as you can see from the slide, what do they see? The other sites, do they see just this image, or do they see me pointing to the slide? Okay. Well, that's terrible.
Unless you want to see that. You want to see that.
Well, I'm not important. There you go.
You like that, Johnny?
Well, it's easier for me to read.
Okay.
Okay. Anyway, I'm in the Department of Family Practice here in San Antonio. I am part of the geriatrics group, and the topic that I was assigned, I'm actually pitch hitting for Dr. Espino, and he developed a wonderful handout which I will direct you to on falls. Everything you could possibly want to know about falls, all the technical details of falls, evaluation of falls is in that handout. And so what I'm going to do is enrich the material in addition to that handout, talking to you about a slightly different but related topic, and that's functional evaluation in WellElderly. How many of you ever seen a WellElder? Hey, there's one. She resembles that remark. Hey, come on. Yeah. How about out there in Kerrville? I know you guys are inside the VA, but you got to see well vets once in a while. Speak to me so I can see you. Hello?
Yes, we all have seen well veterans, well older adults.
Outstanding. Well, that is the group that I will submit to you is most in need of our scrutiny for fall risk and for changes in functional status. Anybody care to describe any of those? Lady who spoke up in Kerrville, can you tell me, give me an example of a WellElder that you've seen? This is audience. Go ahead.
Someone that's able to socialize, take care of their instrumental activities of daily living and their own activities of daily living, and in a self-satisfying way.
In a self-satisfying way, I like that. That's good. That's right. People who are functional, they're independent, they live in the community, they'll run you over with their golf carts if you happen to be out on the golf course. You've seen them driving. These are well older adults, and there's many of them here in San Antonio. Do I change my slides? I changed my slides. Okay. All right. So I'm going to give you some more details on how to recognize a WellElder, because they're more than just the sum of their instrumental activities. I'm going to give you some rationale as to why this is a group you want to focus on. Ooh, now it's dark in here. Now I've completely disappeared. Poof. Don't do that to me. I'm going to talk to you about function versus disease-based prevention. Most of what you will hear people who lecture in geriatrics they'll talk to you about diseases, colon cancer, coronary artery disease, and the prevention of those things. Now, when I say function-based prevention, anybody have an idea what I mean? This is audience participation, by the way. You can't just sit there and sleep. So speak to me. What do you think I mean by function-based prevention? What are we trying to do here?
Well, you want to keep these patients functional as much as possible.
Exactly.
And then you start preventing all kind of things from calluses to dementia, etc.
Yeah, we want to keep them working. We want to specifically prevent functional decline. And with a little, although you guys are all inside of the VA, and the VA has lots of money, so money does not matter. You're in private practice, aren't you? Who said they were in private? You're in private practice. This will be important for you. Something a little special just for you. Okay. All right. What is a WellElder? Well, nationally, about half of people over 65 say that they have excellent health, thank you very much. So those people I would classify as WellElders. They're the kind of person who comes into your office and you say, how you doing? And they say, fine. And you find really nothing wrong with them. And you say, they're not very old, when in fact they might be 75 or 80. That's a WellElder. Most of these people don't smoke in the real world. Now in the VA, it's a different story. I've seen them around the Audie Murphy out front. But in the real world, most of our WellElders do not smoke. Most are close to what we would call a desirable weight. So obesity prevention is not something we would spend a lot of with most of them. That means 30%. We're being generous here. Because in late life, you need those extra pounds when you do get a disease to help you fight it off. And almost 90% of these people will see you within a 2-year period. So you have the opportunity to do some intervention with older adults. I know you guys look skeptical. I know the ladies in Kerrville are like, older adults, oh my God. But you will see them. And I got this data from the Senate, the US Senate, so you can consider the source. Okay. Why do we evaluate people? These are the expectation of life at different ages. So at 65, and this is men and women combined, on average, at least half of them will live another 20 or 25 years. So you want to, at 75, it's 15 to 20 years, and at 85, we're looking at quite an expectation of life. What you want to minimize is the amount of time that additional life is spent with a disability. That's why Pam New had you guys doing all that stuff without giving you the context. So you know what to do, and now I'm going to give you the context to put it in. So prevention of functional decline and screening, I mean, this is where it's at.
Excuse me, why they lump men and women? Because we read all the time that
women have a longer life.
Is much longer. The life expectancy is, if they reach 65.
Yeah, well, I lumped it for ease of presentation. But you're right, women do live longer, but they live a greater proportion of their lives disabled. Did you know that?
No.
Yes.
That's
So who cares if you live a long time if you're going to be disabled? We want functional competence. See, I want you guys to be awake. We want functional competence. So a lot of the stuff that Dr. New, and I'm thinking about the neurologist, Newstead told you before, this is why you want to do it. Because many of my older patients and my mother-in-law have these discussions about why I'm pushing them to do these things. I'm old, I'm not going to live very long. So I have to tell them, look, you have quite a bit of life ahead of you. If you want to continue doing the things that you do, taking care of yourself, you got to get with the program. All right, this is just to give you an idea of what I mean when I say disease-focused. You know this stuff. This is stuff you do all the time. You do lipids, you do PSA, maybe not, a few pap smears in the VA system. All of this stuff, is this going to get at functional competence? No. Just say no. Just say no in Kerrville.
No, ma'am.
Thank you. This is kind of delayed. This is just disease. Where we find a stage of disease will influence a bunch of things, but this is not screening for function. So if you come away with nothing else this afternoon, it's function we want to focus on. Okay. This is function-focused prevention. These are maneuvers that you will do or should start to do in your practice every time you see an older adult, whether they're coming in for something small or something large, some version of this, some piece of this. Now, some of this is quite protracted, and so I'm going to grab a victim from the audience and make them do something I've got that's really short, because in your office, how much time do you have really to do a lot of screening? Not a lot. So you want the thing that's going to give you the most information in the shortest amount of time, right? Right. So is this good for you so far? Am I doing something good for you? Okay. All right. Because my interest here is in giving you information that you want to know. I mean, we're all adults. You're giving up your Friday afternoon, as am I. I want to give you something you can use. You guys know what the Tonetti gait and balance is? Yes?
Yes, it's a long questionnaire.
Yes, it's a long
There's a lot of that.
lots of stuff in there. How many know what the geriatric depression scale is? You forgot. Oh no, we have a demented person. It's a short it's a short screening tool for depression. Why would we talk about depression in the midst of functional and falls? Why? Why would I bring this up? Am I losing my mind? Yeah, being depressed impairs your functional ability. Do you guys do that in Kerrville?
Yes, we agree. If the patient's depressed, they're not going to feel like getting up and exercising or participating in any of their own ADLs.
That's right. What kinds of patients do you see more depression in? I'm sort of leading you here.
For the older patients, 65 and above.
Well,
Chronically ill.
okay, chronically ill, because not all people who are 65 and over are depressed, right?
Recently ill.
Yep. Or recent loss of a spouse, that kind of stuff. How about stroke?
Absolutely. Parkinson's disease.
Parkinson's disease? Yeah. So you really do want to screen those patients. Of course, they'll start to memorize the question. So you'll have to come up with other ways. But you really, every time you see them, you should check them for that. What's clot drawing? Anybody know clot drawing?
Visual-spatial abilities. Visual and spatial.
That's part of it, but there's much more to that than just visual spatial.
I think it's one of the best tests to determine if a person is demented.
If they're
One of the
demented.
best tests, it's one of the best tests for screening for cognitive impairment.
Mm-hmm. So I see Dr. Royal's gotten to you. Is that true?
We couldn't hear that
It's
comment.
in the literature.
I see Dr. Royal has gotten to you.
No, it's in the literature, and we have it in our gym clinic, that
Oh.
we use that as a recognition of early signs of dementia.
That's right. When a person is asked to draw a clock, not only do they have to know how to put things in space, but they have to sequence a task, and then what you ask them is not just to draw the clock face, you ask them to draw the time, 1:45. So they have to put the hands in the right place. This is a surrogate for a specific kind of cognitive function we call executive function. Executive is the mother in your brain. Tells you to get out of bed, put your clothes on, eat your breakfast, drive to work, do what you need to do, go home. So all of that is wound up in clock drawing. Are you surprised? No? Nothing would surprise you at this hour of the day. Okay. But all of these are part of function, because if you don't have good executive function, what's going to happen? You're not going to be able to do the things you need to do in the sequence that you need to do them. You're not going to be able to cook if you don't have good executive function. Well, some of you guys don't cook anyway, but you're not going to be able to pay your bills.
We do.
We do, yes. So this is as much a functional, important component of function as anything else. And people who are executively impaired are at higher risk for falls. That's where all this ties in. All right. More function-focused questions. Say that 3 times fast. Why am I asking about leaking of urine? What does that have to do with function? What function is it asking about? Hello?
Bladder control.
Yeah, continence. Continence. And what does it suggest when someone who was formerly continent starts to leak? Good star. You get an A for the day. Yeah, people who, not always, but that's a good source. People, maintenance of continence is a complex function that incorporates cognitive, physical, neurological, all kinds of things. So in order for you to leak, all of those systems. Yes, ma'am. Go ahead.
Perhaps you're breaking up if the mic is not close enough to your.
It's not about me.
Oh,
I think,
okay. She's gonna fix me.
I don't know if I can, but your voice is
Up and
getting
down.
lower.
Okay.
I'll see.
I'm trying not to yell at the folks in San Antonio, but it seems like I have to scream to be heard in Kerrville.
Is that any better?
So are they picking me up here too?
Yeah, these are the mics for distance learning.
Thank you.
Oh, I thought this was.
No, that's just for the videotape.
Oh, man, this is complicated. You're testing my cognitive function here. Okay, is that better? Should I not move back and forth?
That's much better, thank you.
Okay, I'll stand on this one spot and not move. Continence in the context of function. Any ideas out in Kerrville? Talk to me. Is El Paso back? Are you back?
Yes, I'm sorry, could you repeat the question?
Okay. Why are we talking about continence in the context of falls and function?
Chances are, I've had patients before that when they were incontinent, they were afraid to get up and walk because they didn't want to leak, because it was very embarrassing and they felt like they were losing control. And they would end up sitting most of the day for fear that if they got up, then they would have some leakage.
Okay. So, would the leakage make them fall?
No, but the loss of mobility would, if they had depressed balance system to begin with, then the more you don't use it, the more you lose it as far as the balance system.
Okay.
And so they would, all in all, their function would decrease, which in turn would exacerbate whatever balance problems they may have had to begin with.
Okay. So, yeah, that's good. That's a good way to put it together. The other thing that the urologists point out is that guys who are having problems with BPH, so it's not a problem leaking urine, but it's a problem of nocturia, will experience falls making those nightly trips. So anything, that question could be phrased more broadly. Anything involving disorders of continence or excess frequency in urine are a risk factor for falls. And of course, here's the standard question: 2 or more falls in the past year. That's the simplest question. People fail to ask it in a primary care encounter, but it will give you so much information. And most people can tell you pretty much, because falls are not common, so they can tell you pretty much if they've had 2 or more falls in the past year. These other things, again, are more subtle things, but change in the household. If you've moved, someone's moved in and out. Complaints about TV volume, hearing. Recent eye exam. Why would you need a recent eye exam in the context of falls?
Or check the vision.
Yeah, you want to be able to see objects. Or if you've got glasses that need to be changed, I don't know how many of you wear bifocals, but you have these blended lenses like I do. If you look down, if you're looking straight down, that's one thing. But if you look down and you catch the bifocal part of your lenses, then the world is not quite where it should be. So eye exam and updating lenses is an important part of fall prevention. So this is the part for you, okay? Medicare will pay for disease-focused prevention activities. And you can see all of these up here. Medicare is very good at chasing disease. We have yet to educate them, though, about function maintenance. We would love for Medicare to pay for exercise programs. So one of the things, when I talk to primary care docs about this issue, what you have to be able to do is give your patient a recommendation for what to do. And it's one thing to say you need to do 20 reps of low weight for 5 times a day, but have you ever exercised at home? Boring, isn't it? You know, get on that treadmill in front of the TV set. Boring. You don't get the social stimulation, which is another part of prevention of frailty, falls, and instability. So these are outlets, venues for function-focused preventive activities. One way to think about it. Do you have a Y in Kerrville? Hello, Kerrville.
Yes, we're still here.
Okay, do you have YWCA or YMCA or health club out there?
We have several health clubs, in fact, 3 organized ones. One which is a physical fitness center targeted particularly to the elderly adults called Fit, which also provides some medical services as well as an exercise program.
Do they really?
And most insurance companies will pay for the initial physical and membership fees, and then the person though is responsible for the monthly fees.
How much does that cost?
I think that was around $50 a month. I think it's about $50 a month.
$50 a month.
That's a lot of money.
That's a lot of money. They must be rich out there in Kerrville.
The we go to is only $39 a month.
Okay. Okay. But this is the sort of thing you want to direct your people to. Here in San Antonio, some of the local colleges have courses that are designed to improve cognitive skills for our seniors. And so because it's physical and cognitive you want to work on. So you want to get your patient thinking, I've got to work on my brain as well as my body. A friend of mine told me about the Institute for Texan Cultures, and elderly Texans just love Texan cultures. So they have senior university, so you can get people in the bus, bring them to the Institute, and again, it's social, it's cognitive, they're walking, all of that is good for preventive, for functional prevention. Now, okay. See, my talk is really short, so you guys will be happy about that. The one thing I want to urge all of you to do, this is where I need a volunteer and a chair. That's the wrong kind of chair. Okay. Who wants to be my, yeah, come on over here. All right.
There's already a senior, so.
That's right. There you go. Have a seat in the chair.
Okay.
Now, every visit in our clinic at the Brady Green downtown, we get every patient to do this test with every visit. It is short. It is reasonably accurate. It's been validated in other studies. And over time, if you do it over time and you watch people, you can get a good sense of who's going to fall. Because the last thing you want to have happen is to get that phone call in the middle of the night. Mrs. So-and-so has fallen, and now she's in trouble. or Mr. So-and-so has fallen, and now you've got to go take care of their fracture. And many people, including the family, act as if they're surprised when they get that phone call, when if you sort of looked at them with a critical eye, you could pick it up. This is called the Get Up and Go test. How many have ever done the Get Up and Go test?
We did a half an hour.
You did? Well, all right, you did it. So what's the, did you guys do it in? No, hey, get up and go. All right, see, this is, you guys are just too smart for me. You should do it every visit, and make a note of it. Because it's the one thing that's going to help you figure out who's at risk before they fall, and that is the name of the game. What's the most dangerous room in the house? Bathroom for falls, and the place they're most likely to fall, because they're doing stuff in there that puts them at risk. I won't name those things, but you know what they are. I'm going to take questions from the floor now, if you've got them. But I wanted to put this in context. I want you to think about well elders as well as the frail ones. Because while the frail ones do the vast majority of the falling, a fall can be a lethal event for an older person. So what you want to do is prevent that first fall. Yes? Just nod your heads if you agree. Yay, they're awake in Kerrville. Questions, comments? There's no blog, there's no place like, my email is MILEST. I'll pause for a second. Can I put it here? Okay. Can they see that?
Yeah, there's another thing. You need it over a little bit more, Dr. Lyle.
Okay. Okay, I'm going to stand out of the way. That is my email address. I would, if you've got very specific questions that I didn't address, I'd like to, there's a dot here. Okay? If you've got some very specific questions that I didn't address, send me an email. I love to get email. Don't send me any viruses. I hate viruses. What else?
How do you reconcile the fact that taking care of these seniors who have significant problems is time consuming, is staff intensive, and then the reimbursement is not that great? So how do we do it?
How do we do this?
For the primary care physician to do that on his or her own,
Right.
is difficult.
It's a problem. No, that's that.
I had experience that I was running a senior center which was sponsored by Santa Rosa Hospital.
Mm-hmm.
But Santa Rosa decided that they didn't want to have any more many outpatient facilities because they are on the red.
Mm-hmm.
And you saw the papers, they closed a bunch of clinics and so on. So I had a facility, but then if I try to see those patients in the best way possible, I'm going to be in trouble because I won't be able to pay the bills.
Mm-hmm.
Screening this, documented the situation about dementia, equilibrium, falls.
Mm-hmm.
Substances.
No, I understand what.
Let alone, the usual medical problems.
Yeah, no, I understand what you're saying.
For example, this patient takes several medications. You want to type the list of the medication to say what the medications are for. You have to update those things. You have to adjust the medications, and then you have to type a lot, etc. In other words, it's like if you wanted to do a really good job, it's difficult. Now, with the hospitals, there is some sort of legislation that the hospital can get some money out of the use of the outpatient facilities. But you cannot do that as a practitioner. You have to go through a hospital. So I have a beautiful center that maybe I can have some, do you hear somebody that wants to sponsor that one? Just let me know.
No, that is the problem. I have colleagues in private practice, and they are now refusing to see Medicare-only patients, which I think is not right, but I understand their concern. For those of you who didn't hear what he asked about is the problem of delivering the kind of care we'd like to deliver, the screening stuff that I talked about, and not go broke. Because Medicare, we estimates it pays about 58 cents on the dollar for what you bill. And if you don't document every little thing that you do, then you're accused of fraud. We just went through that at the university. It wasn't really fraud, we just didn't document well. What I've seen done successfully in private practice, I mean, our practice has about 25% frail elders. Those are the people who cost the most money, those are the people who take the most time, and those are the ones who will kill you in private practice. The people I know who survive have their frail population be about 1 to 3% of their overall Medicare population. That is about all they can tolerate on their bottom line. Now, if you're in some community like New Braunfels, where the population of over 65 is high, that's going to be a problem for you. But I think that I gave a talk to the residents on this really the same issue. The other thing that you can do, which is what we've been doing downtown, is documentation is key. It might even be worth your while to hire somebody to do that job for you. I mean, whose job it is to follow you around and help you document the visit. We've gone to laptop system. We have check boxes. Because we have residents, and there are special rules and regulations about what you can bill when you're in the process of teaching. And of course, they change the rules. Just when you finally get it down, they change the rules. But the documentation is key, and I think in private practice, spreading the load in the community, I think the primary care docs in the community are going to have to spread the load. That means the guys who don't take any are going to have to take some. And guys like you who are doing a lot, more than their share, might have to make referrals. I won't say turn people away, because I don't, we can't do that. But I appreciate what you're saying. Does that help? Sort of?
Yeah, I mean, it's a fact. It's something that is difficult. Right? When I was with the Santa Rosa, I would dictate. Now, but if I dictate now, pay the transcription, it's very expensive. But that was, was nice when I could have these people taking care of the transcriptions. It's faster, it's, documented a whole lot, and then the other stuff is documented other things, et cetera. So it's beautiful care.
Yeah. I will tell you, not to scare you, but there are already in Bexar County 250,000 people over 65 today, and that number is going to double in about 10 years. And so those people, the people who are moving into being 65, are the people right now that a chunk of them, a quarter of them, are uninsured. So they arrive at 65 with the physiology of an 80-year-old, because they've been temporizing health care. Those are the people that really kill you, because they come in at 65 barely hanging on by their fingernails, that their diabetes hasn't been well controlled because they haven't been able to get good primary care, or whatever, heart disease, hypertension, you name it. And they arrive, they get Medicare, and they immediately consume at a very high level. It is a system problem that cannot be solved by just more documentation. It's something else above us society or the government or tobacco money. You didn't hear me say that. You have to erase this tape. But anyway, any questions from El Paso or Kerrville?
Actually, I do have a question, and it sort of follows up with the question that the gentleman just had. Do you know of any of the prevention programs that, whether it be by, better documentation or play of words or whatever, that we could have better success with being reimbursed for example, large exercise groups in nursing homes, other than people who volunteer to do that? Are there any programs that you feel Medicare would look upon favorably in terms of reimbursement that would be effective in preventing, with preventative measures?
Well, one idea that we've gotten here in San Antonio, see, San Antonio is the obesity capital of the United States. No. One of the things Medicare will pay for is weight reduction treatment. You can bill for that. And so if you can have a proportion of people in your group who are there, they're exercising and it's part of your therapy for weight reduction, you can document that and Medicare will pay for it because they've now started to understand that has an impact on other parts of their disease. So I'm telling all my friends, bill for weight reduction.
But you don't see a lot of obesity in seniors. Well, I don't remember.
I don't know, the ones we see downtown are pretty round.
Because usually there is the suggestion that if somebody is more than 65, probably you shouldn't push too much on weight loss, unless of course there is significant
Yeah, well,
overweight.
and we're not talking about, how much success do you think you're really going to have in weight reducing these people? What you're really after is improving their functional capacity, their strength, their endurance. You're lucky if you can attain, in a person who's otherwise okay, a 10-pound weight loss. If you can get them to drop 15 pounds, you can see a significant improvement in their blood pressure. They don't have to look like Twiggy. Are you guys old enough to remember Twiggy? See, I teach first-year medical students, and you say Twiggy, and they go, huh? So, yeah, Medicare is starting to understand pieces of it, but the regulations are still strangely written, like they cut back on the physical therapy that they would pay for, which I think is it's really ridiculous. So, did I answer your question, El Paso?
Yes, thank you.
Mm-hmm.
You did.
Okay. How about Kerrville? You guys want to take a break, don't ya? We're going to give you a break. Well, send me an email if you think of something that I didn't talk about and you want to hear some more about. That's what we here at the university are for, my colleagues and I, to give you the latest, the hottest, the greatest scoop on everything in geriatrics. Lily?
I would like to see more talk about the WellElder, which seems to be...
Yeah. Well, that's my specialty. Well, seniors, because that's like 75 to 80% of adults over 65 are well.
65 to 70?
No, I said, yeah, well, 75 to 80% of older adults over 65 are well. Keeping them that way is what we want, because that will hold down costs. That will get us around some of it. And that makes, people are happy to be well. What we want to be, you want to bop till you drop, right? That's right, that's the way you want it.
Is that going to take a preventive medicine approach though, or what is that going to?
Well, it means that at every stage, even if you have a little bit of high blood pressure, it means we focus on preventing the next thing, or we focus on you know, I don't know. But it's going to take a preventive approach rather than a treatment-focused approach.
Nutrition, exercise.
Yeah. I'll tell you, the biggest problem, since you guys got me on a soapbox, it's Friday afternoon, I think the biggest problem facing the growing elderly population is what to do with the time on their hands. You know, people use the retire word and they jump off, it's like they jump off a cliff. That is a big contributor to functional decline. I don't think retirement is an option anymore. A third, in this one study, I'm involved in a cohort study of 3,000 older adults who were selected because they could walk a quarter mile with no difficulty. They live in Pittsburgh or Memphis. 50-50 male-female, 50-50 black-white. 30% of those people work. Why? Because they need the money. You know, financing late life is going to be an issue. It's going to be more of an issue probably for my generation than it is for the current crop. That functional competence is going to, the bar of functional competence is going to be raised in the future. It's not going to be just enough to be your IDLs, ADLs, and to be happy. You're going to have to be able to work. You're going to have to be able to cross the street without getting hit by a car. You're going to have to be able to drive. In Texas, mass transit, we're having a light rail vote tomorrow in San Antonio. Let us hope that they voted in. Those are the functional issues facing our older population, and I think as a healthcare provider, this is what I'm looking for. These are the kinds of things that I'm trying to help my patients maintain, or making them think about that they have to do. Balancing their checkbooks, important stuff. Okay? Colville, we okay?
We're fine, thank you very much.
Okay, I'll stop talking, take a break, come back at what, 4 o'clock? Well, not 4 o'clock El Paso time, 4 o'clock San Antonio time.
Right.
Thanks for your attention.
Thank you.
All right. Told you it would be different. So next year, just ask me to talk and I'll do.
I will.
I'll put together my own talk.